meeting is now being recorded.
Okay.
Great. Thank you.
Okay, go ahead.
Thank you so much, and good afternoon, everybody, and welcome back to this third webinar. As Karen said, this one is about asthma triggers, and I currently work at Priority Health. I'm the Director of Commercial Care Management. Previously, I managed the local asthma coalition, the Asthma Network of West Michigan. I'm also a board-certified nurse practitioner, and I've worked previously in an allergy office, seeing patients with asthma and allergies. I'm a certified asthma educator. I have asthma myself. I have a daughter with asthma, so I live and breathe asthma on a daily basis. And I'm here today to talk about triggers. There are 3 more webinars after this one. Next week will be about asthma action plans, and we'll talk about some case studies. And the following week, there will be 2 webinars. One will be on COPD, diagnosing and managing, and the second one will be on the various COPD medications. So today, we'll be talking about environmental management of asthma or asthma triggers. So an asthma trigger is really comprises a variety of stimuli, or basically anything that can cause airway inflammation or swelling and bring on an asthma flare. So it would make sense that the more triggers we can reduce or even eliminate, we will hopefully decrease the need for asthma medications and reduce symptoms and reduce exacerbations. So an asthma trigger is described as any agent or factor that contributes to asthma severity. They can be additive in nature. That's why I have the baby blocks here, because, perhaps any given day, one trigger may not be enough to trigger someone's asthma. But when you add them together, I always say someone who has asthma, as I do and some of you might, we have a cup that's already half full. So the more triggers you add into that cup, the greater danger there will be. The cup will overflow, and you will have an asthma flare or exacerbation. Those of you who don't have asthma, you have an empty cup, and you can be loading in triggers all day long, and it won't cause any trouble for you. There's also variable sensitivity. So not everybody with asthma is sensitive to the same triggers. It's called the snowflake theory. So not all, they always say if you know one person with asthma, you know one person with asthma, because everyone's asthma is a little different, and they may have different triggers and different sensitivities. So no 2 people are necessarily alike with exactly the same triggers. And triggers can be found many, many locations, in home, certainly school, workplace, outdoors, entertainment venues, the car, anywhere. And there is a stepwise level of control for asthma triggers. So it doesn't mean just because someone has asthma, we have to rip out all the carpeting out of the house and that sort of thing. There are certainly stepwise approaches, and we'll talk about that as we proceed. We focus primarily on the bedroom and make that as asthma safe as we can, first of all, and we can move on from there. So there are various categories of triggers. Allergens, and we'll take each of these individually. Allergens, irritants, respiratory infections or colds. Exercise is a known trigger. Weather changes. Stress can trigger asthma, just as stress can trigger any chronic disease. And there are other triggers that we'll talk about at the very end as well. The one trigger, obviously, we don't want people to avoid is exercise. So we're going to begin with the difference between allergens and irritants. And with allergens, there are allergens both indoors as well as outdoors. So indoor allergens that we may all be familiar with would be animals, any furry, feathered animals in the home, pets, dust mites, cockroaches, moles. Those are things that people can develop an allergy to and can trigger asthma in those susceptible individuals. Outdoors, allergies can include pollen, such as tree, grass, weeds, moles. Those can all be allergies. And then irritants, there really is no evidence of allergy to these different triggers, but these are things that just by nature trigger those sensitive airways in someone who has asthma. We talked about at the very first webinar that people who have asthma have more sensitive airways than those people who don't. So our airways are more twitchy or irritable or hyperresponsive. So irritants can trigger those airways very easily, and those include environmental tobacco smoke, combustion byproducts like wood smoke from fireplaces and that sort of thing, barbecues, outdoor air pollutants, scented or unscented consumer products, and cold air is also another well-known irritant for those sensitive airways. So let's begin with indoor asthma triggers. And most of us, I think you probably would agree, we probably spend most of our time indoors. 90% of our time, on average, is spent inside. And I attended an asthma conference a number of years ago, and one of the indoor air experts actually called this the Annette Funicello phenomenon. Now, most of you are probably too young to remember the Mickey Mouse Club, but Mickey Mouse Club was one of the very first television programs that came on the air in the 1950s and was targeting children. So in the 1950s, with the advent of television and children's programming, children came inside, and they really haven't left since, because obviously television has exploded beyond the 50s. But in addition to that, there are computers and video games and all kinds of things that are more likely to keep children indoors than send them outdoors when they used to play outdoors the majority of the time generations ago. So Annette Funicello was part of this Mickey Mouse Club. So we're not blaming the dramatic rise on asthma on poor Annette, but she was considered a factor in that because of the Mickey Mouse Club and the advent of television. So also, outdoor air pollutants come inside every time we open our windows or our doors. Those pollutants are added to indoor air, and the health effects are, obviously, pollutants are respiratory irritants. There's also allergens that fly in, and there can be fetal effects as well. So if we can reduce exposure to indoor allergens and irritants, we can reduce asthma symptoms. But prevention really is the most important asthma management tool. So allergens, an allergen is defined, or allergy is defined as a condition in which the body's immune system overreacts to a foreign substance that has been breathed in, swallowed, touched, or injected. So it really is basically a benign substance. A body identifies a normally harmless object like pollen or animal dander, not hurting anybody, but it's typically benign. But if you have that predisposition to allergy, your body may identify that as an invader and overreact. The immune system goes into overdrive and fights this harmless invader. So approximately 70 to 90% of children with asthma have allergies. So asthma and allergies in children go hand in hand. Most children with asthma have allergies as well, and at least half the adults with asthma also have allergies. So there's a very strong connection between asthma and allergies. So we get allergies under control. That certainly helps us to get asthma under control. We'll begin, first of all, with pets. That's actually my little Shih Tzu up there in the corner, Oscar, who I'm not allergic to, thank goodness. But with pets, it's, and when I was a nurse practitioner, I would hear almost on a daily basis, well, I have a dog, and I know I'm allergic to dogs, but my dog is hypoallergenic. And I really didn't want to burst their bubble, but truly the only hypoallergenic dog or cat would be a dog or cat with no skin. And that would be a really ugly dog, because it's not the hair, it's not the fur, it's the dander. It's the skin cells that they shed. And there's also protein in their urine and their feces and saliva, and that becomes airborne. We breathe that in and become sensitized to it, and then it triggers us on an ongoing basis. So it really is not the hair, it's the dander. And allergens are present even in homes and public places that don't contain animals, because dander is so prevalent and will travel on people. They even found cat dander in the space shuttle. And there was never, obviously, a cat on the space shuttle, but the astronauts brought it in on their person. And certainly in schools, children will bring in the dander from their homes, and there are very high dander levels in schools as well. So the recommendation is, if you have a pet and you have a known allergy to the pet, is to the very least keep the pet out of the main living areas and the bedrooms. We really want to focus on the bedroom and make sure that that is as allergy safe as possible. And the reason for that is because we all spend a third of our lives in our bedrooms. If you sleep 8 hours a night, that's a third of your life. So the more we can work on that bedroom and make it allergy safe, asthma safe, the better off you're going to be when you're encountering other allergies throughout the day that it might be unavoidable. So getting the pet out of the bedroom is critical. Installing HEPA air cleaners, and that's important that it be a HEPA air filter. The brand doesn't matter as long as this is HEPA in the main living areas, especially in the bedroom, because cat, dog dander in particular is fairly light, so it stays suspended in the air for a long time, gives you a lot of time to breathe it in, become sensitized to it. These air purifiers help draw some of the dander out of the air and just keep the bedroom a little more allergy, asthma safe. And obviously avoid furry feathered pets or products made with feathers if you have a feather allergy, like down pillows and comforters. We also recommend using a vacuum cleaner with an integrated HEPA filter or double thickness bags, whatever we can do to reduce as much of that dander as possible. It may become necessary at some point to remove the pet from the home if we cannot, despite all these other avoidance measures, get someone's asthma under control and they have pet allergy. There is a website for adoption or foster care, petfinder.org. They will not destroy an animal if no home is found for them. Now, once the animal leaves, if that becomes necessary, even if that house is cleaned aggressively after removal, it can take weeks or even months. It can take actually up to 6 months after the animal is gone for all the dander to disappear or disseminate. So it really is there for a very long time. Now, there are some controversial studies that shown that pet washing can be effective, and others say it's really not that effective, and the best avoidance measures are to eliminate the pet or at least keep the pet out of the sleeping area. Of course, this is one method. It's a cat shower. It's a Gary Larson cartoon, but that's something that cats might enjoy. Rodents are another significant asthma trigger, and the most potent source of allergen is the rodent proteins that are found in the urine and also somewhat in the dander too. Again, they're furry animals. The rodent allergens accumulate in high quantities in the litter, and that's a major source of airborne allergen. Now, there was a landmark study, the National Inner City Asthma Study, and this found that in a third of inner city homes there was rodent allergens found in those homes, and 21% of those children had sensitivity to rats. 21% of that allergen was found in those inner city bedrooms. So exposure to rodent proteins and rodent allergens has definitely been correlated to missed school days, increased ER visits, and hospitalizations. Dust mites are considered the #1 indoor allergen, and dust mites are those little microscopic creatures. You can't see them with the naked eye. They thrive in mattresses and pillows and upholstered furniture and carpeting. They don't hurt anybody, they don't bite anybody, but the problem is they are highly allergenic. So if someone has, again, a tendency towards allergies, if they have a history of asthma, exposure to dust mites can trigger asthma on an ongoing basis. Now, there are some increases in the summer and fall. Dust mites do like humid environments. That's why there probably are fewer dust mites in Arizona and some of the arid climates. And their major allergen is contained in their fecal pellets. So it really is the dust mite feces that are so highly allergenic. And what happens is, when someone lies down in bed, those particles, whether it be the dust mite carcasses or their fecal pellets, become disturbed quickly, and that's when it becomes airborne, and we can breathe that in, become sensitized or triggered by that over and over again. So it is important to make the bedroom asthma safe. So we do recommend encasing the mattress and the pillow and the box springs excuse me, in an allergen impermeable cover, and that will seal in the dust mites in the mattress and not allow them to escape and trigger someone on an ongoing basis. The HEPA filter also will help reduce the dust mite in the bedroom, but also by reducing clutter, cleaning, dusting weekly, minimizing or eliminating the stuffed animals in the bedroom. All those things can help. It may become necessary when we talk about a stepwise approach to replace the carpets at some point if the other avoidance measures have not been sufficient. We do recommend reducing indoor humidity to less than 50%. Using a dehumidifier can be helpful. Again, dust mites like a very humid environment. So we also recommend using humidifiers or vaporizers with caution, if at all, because they do tend to proliferate the mite population, and they also do lend themselves to more mold growth as well. We recommend washing bed linens weekly in hot water, minimizing upholstered furniture, if need be, replacing blinds with shades which are easily washed down. And then if someone does have stuffed animals, they can actually wash them in hot water. That will kill the dust mites, but you have to do that on an ongoing basis. And then you can even put them in the freezer for 24 hours, and that also kills dust mites. And again, I said it may become necessary to remove the carpets from the bedroom. Also, there are carpets in other rooms that are laid on concrete, like in the basement. That is also a source for dust mite growth and mold growth, too. Cockroaches are, again, very highly allergenic. You may not realize that, but they are highly allergenic. People can become sensitized to them, and they can trigger asthma and allergies on an ongoing basis. When we would test for environmental allergens, many times people would show that they were allergic to cockroach, even if they've never had a cockroach in their home. But cockroaches are so very prevalent, you'll find them in many of the venues where we might visit on a daily basis. They are oftentimes in schools, restaurants, shops, stores, movie theaters. They're just everywhere. And so whether or not you live with them, you are exposed to them oftentimes, and if you have that predisposition to allergy, you can become sensitized. So the cockroach, the part of the cockroach that is so allergenic is in their saliva, as well as their feces and their skin shedding. So even if you were to go in and do pest extermination and kill the roaches, if you don't remove them, that really is not helping much because the dead bodies decay and those become airborne, and people can breathe in the dust and become sensitized to those. The levels in the bedrooms are most associated with sensitization and disease, and as I said, significant levels have been found in inner city schools. Cockroaches is thought to be the dominant indoor allergen in many urban areas, and there has been a sensitivity to cockroach found in 30 to 50% of inner city children with asthma. So it's very, very prevalent. And again, in that landmark study, the inner city asthma study, exposure and sensitivity to cockroaches was the best predictor for asthma morbidity. So to control cockroaches, it's important to block their entrances, dry them out. They also thrive in humid environments. Don't leave garbage or food exposed. Use poison baits, gel, traps. It might become necessary to use professional extermination, but that can be difficult for someone who has asthma. They would have to be kept out of the house until that has been done. And then it's very important to do thorough cleaning after extermination so the dead cockroaches are not left behind. But it's difficult to do because, especially in multi-unit dwellings, you can totally eliminate them from one apartment, but then they were in the surrounding or neighboring apartments, and they will just recongregate in that apartment that was cleaned out. So it is difficult to do that unless you treat the entire apartment complex. And it's possible to reduce the allergen level, but not necessarily to reduce the disease, depending on the degree of infestation. So they are very problematic. There's also integrated pest management, which is a more non-toxic, environmentally friendly way to eliminate them, and that can actually be quite effective. There's even ways, there's something called birth control for cockroaches. So they, when the baby roaches are born, they are not allowed to live to maturity where they can reproduce. So there's very unique ways to do that are non-toxic. Molds are also a well-known asthma allergen, and they reproduce by making and releasing spores, which are very tiny, so they're easy to inhale. They become airborne when they're released by the mold spores or disturbed through physical contact, and mold allergy also is correlated to asthma and asthma severity in both children and adults. It's also correlated to nasal allergies or rhinitis. And again, this also you'll see in very humid, damp environments, and especially with basement or lower level areas, damp insulation, plaster drywall carpets, even in HVAC systems, if there's ever been water intrusion or water leaks, that's a prime place for mold to grow. So to manage molds, it's important to repair any leaks, clean moldy surfaces. I know that there are many schools that have mold issues, and that can certainly be a factor for those children with asthma who attend those schools. It's important there also to keep the humidity to less than 50%. Avoid carpeting on any cement floors. Again, if you have carpeting, and they do that, schools have that oftentimes, carpet on cement floors. If there's ever any water intrusion, there's almost assuredly some mold growing underneath that. Using bathroom and kitchen fans is helpful, but you'll also find mold this time of year, certainly in wet leaves, compost piles, etc. And at some point, it may become necessary to do some professional mold testing and remediation if there's an overwhelming level of mold in the home. We're going to move on now from allergies to irritants. So remember, allergies had an immune basis where someone is exposed to something and develops an overwhelming immune response. Well, irritants, there really is no immune response. These are substances that are simply irritating to those very sensitive airways. So an irritant is an inhaled substance that triggers inflammation and bronchospasm in those sensitive airways of people with asthma, but there's no immune response. So, of course, this is my feeling, too. The real reason dinosaurs became extinct was because they smoked. Tobacco smoke is definitely the universal airway irritant. It certainly would irritate many of you, even who don't have asthma, but those of us who have asthma, there's no question that it's a significant irritant. Whether someone who has asthma themselves will start smoking, and I had patients with asthma who smoked, and some of them were steroid dependent because they couldn't breathe and they continued to smoke and had to be on steroids on a daily basis. It is a direct assault on the lungs and throughout the body. Or if you are exposed to secondhand smoke, environmental tobacco smoke, that is a well-known asthma irritant as well. So tobacco smoke, the effect of active and passive smoke on asthma patients is, we know that tobacco smoke contains more than 4,000 toxic substances. Over 40 of those are carcinogenic. We know that there is a profound irritation in the upper airway and the lower airway, and increased incidence of lower respiratory tract infections. There is definitely increased frequency of asthma exacerbations. And not only that, but it has been found that children who live with smokers have a higher tendency to develop asthma, even if they don't have that genetic predisposition. That's how strong an irritant tobacco smoke is. And it's not just cigarette smoke, it's pipe smoke and cigar smoke and all the other smokes. So the control measures are important. You have to use a realistic, supportive approach. Don't underestimate you as a healthcare professional, talking to parents and talking to patients themselves, and just tell them it's not healthy, you can't smoke around your child. I've told that to patients, and they said, no one ever told me that before. That may be or may be not true, but you can't reinforce that often enough. So educate them about the negative effects of environmental tobacco smoke or tobacco smoke on their own health. And then there has to be a practical plan of control. You just say you can't smoke around your child and leave it at that. That probably will just fall on deaf ears. But give them a practical plan. If they have children with asthma in the home, we ask that you smoke outdoors at all times, never in the home, even if the child's not there, because sometimes people will say, well, I only smoke in the home when my daughter's at school. Well, that doesn't matter because that smoke will linger in the air for hours and can trigger her when she returns home. So never smoke in the home for any reason. Always take your smoking outdoors, even going so far as to suggest a smoking jacket, and I don't mean a velvet jacket with an ascot, but a smoking jacket, a jacket they would wear outdoors only. Hang it up in the porch or hang it up in the garage and then come in without that scent on their body. Certainly never allow smoking in the car because it's such a small confined area, and that will irritate a child's airways on an ongoing basis. And obviously choose smoke-free child care settings. And now it's easier, fortunately, much easier than it was when my daughter was growing up, to find smoke-free restaurants and smoke-free shopping malls. Believe it or not, when my daughter was growing up, we had to dodge around the smokers in the mall because people were allowed to smoke in those days. So things have changed definitely for the better, but it is still important to avoid those exposures as much as possible. Now, cotinine is a major metabolite of nicotine, and it can enter the body of a non-smoker, and exposure to cotinine can be measured by analyzing these levels in the blood, saliva, or urine. So it really is a telltale sign of how much tobacco smoke a child or an adult has been exposed to. And the preferred method of measuring nicotine over time, because cotinine remains in the body longer, so it's easier to measure, it remains in the body longer, and it's a good proxy for how much smoke this person has been exposed to. Nicotine is highly specific for tobacco smoke, so the cotinine levels will track that exposure to tobacco smoke and its toxic constituents. Studies have found that children with asthma with high levels of smoke exposure compared to those with low levels were more likely to have moderate or severe asthma. So it can at some point, if a child, for example, lived with smokers and they continued to smoke around that child, and the child was seen in the emergency department, urgent care, or was hospitalized time and again, you could actually develop a case for medical neglect based on cotinine levels. If the child was taken to a lab and had urine or salivary cotinine levels drawn, it could approach at some point the level of medical neglect, and the charges could be filed for that purpose. Now, obviously that's a last resort, but it is a possibility if a child is definitely suffering as a result of that tobacco exposure and they have asthma. So these are just for your reference what those cotinine levels are from the limit of detection from low levels to high levels. But it is a nice tool to have if there is concern. I remember there was a child that we saw, and every time she came back from staying with her dad over the weekend, she would have a major asthma flare on Monday after that weekend was over. And we did send her to the lab and had urinary cotinine levels drawn, and she had high levels, and there was some ammunition there for at least a discussion and referral to Child Protective Services for that ongoing tobacco exposure. So there are other airway irritants, and these include other sources of smoke, such as fireplaces, stoves or heaters. Wood-burning stoves this time of year are going to be a significant concern. Kerosene heaters, campfires. We also want to avoid outdoor fires, including leaf and grass fires. I was dismayed to see that recently the city of Grand Rapids passed an ordinance that allows for fire pits in the backyard. And my thought was, why? Why do we need to add more particulate matter into the air for people who are already struggling some days to breathe? So to me that was unnecessary, but that's just my little editorial opinion. But otherwise, outdoor industrial pollutants, other irritants, and these could even be pleasant smells like perfume or cologne or air fresheners. Anything with a strong fragrance, pleasant or not, can be enough to trigger somebody with asthma because that's an airway irritant. If you can smell it, you can breathe it in, and it can trigger asthma. So chemical odors are a variety, from paints and solvents to pesticides, adhesives, particle board, vinyl flooring, tiles. So some people say, well, I have asthma or allergies, or my child does. Well, if we can afford it, we're going to build a new house. Well, that may be well and good, but even with new construction, just think of all. If you've ever walked into a parade of homes, brand new home, and you think of all the smells there and all the off-gassing from the new carpeting and the new flooring and the new tiles, and that can certainly be a concern until all that off-gassing has dissipated. But toners from photocopiers, even cleaning agents used in the home, even dry clean clothes. I recommend that if you bring dry cleaning into the home, that smell from the dry cleaner, take it out of the plastic, let it hang in the garage for a day or so, let that smell dissipate, and then bring it into the home. So there are definitely ways to avoid those things. Certainly one of the easiest ways is to not use any scented products around people who have asthma or allergies. And this is very easy to do. We recommend fragrance-free settings in the workplace, certainly in the schools. Why would we want to add to that mix and add to that cup of someone who has asthma and fill up their cup and have it spill over into an exacerbation when cologne and perfume is very easy to avoid? Now, work-related asthma is defined as asthma caused by exposure to an agent encountered in the work environment. And the important thing here is to recognize what that pattern of symptoms is. So the timing of symptoms, does someone's asthma improve when they have a vacation day or when they have days off for a week? Are they better over the weekend and then get worse again on Monday? Do the symptoms worsen as the work week progresses? If they are checking peak flow, is there a worsening of that peak flow? Does that drop between work and non-work? So there are ways to identify whether the work environment is indeed triggering asthma, but realizing that sometimes it's not realistic to say, well, find a new job. That's easier said than done. They may not be able to do that. Can they wear a respirator? Can they keep that job but maybe move to a different area? Can they move to a different position where they're not exposed to those chemicals or whatever it is they're exposed to? There are reports. Several years ago, there were some mortality review panels for the state of Michigan that looked at asthma fatalities in both children and adults. I served on the children's panel. There was an adult panel, and on the adult panel, there were several instances of adults who died after being exposed in the work setting. One was a young woman who worked in a bar that was very smoky, and she had a fatal asthma attack there. Another one was a young man who was spraying bed liners on a pickup truck, and it was poorly ventilated and had a fatal asthma attack there. So, it's not that this is inconsequential. Certainly exposure to work can be very significant. So let's move on to outdoor asthma triggers. Pollens certainly are considered asthma triggers if you have pollen sensitivity. And it's important, if we can, to limit exposure during pollen season by staying indoors with windows closed if they can afford that, if they have air conditioning. But also we can monitor local weather forecasts. They're usually pretty good about telling the pollen counts. There are pollen count apps that you can put on your phone and check pollen counts on a daily basis. Use air conditioning if possible. There's also very highly effective medications that we can use for upper airway allergies. And again, whatever we can do to treat the upper airways, the nose, the throat, will help with asthma and the lower airways. But even something as simple as taking a bath when you come indoors. I used to tell parents, when your child has been outdoors playing all day during pollen season, when they come in for the night, have them just get in the shower, because pollen is very sticky. It's going to stick to their body. It's going to stick to their hair. Change clothes, shower, and that removes a good deal of the pollen that they're exposed to. But pollen certainly, in Michigan anyway, have certain seasons that we are concerned about. We have tree pollen season that usually just starts at the end of March, April into May, and that overlaps a little bit with grass pollen, which is the end of May through June, July, kind of through the 4th of July, maybe sometimes a little bit later. Get a little bit of a break in the pollens there until ragweed hits, and that's usually right around August 15th. And ragweed is still evident out there until the first hard frost. So through early mid-October, this is the tail end of pollen season right now. Now, some people are exposed or are sensitive to one. Some are sensitive to all the pollens. And they can have trouble ongoing throughout the entire pollen season. So for them, their pollen season literally could run from, say, April 1 to October 1. And that's a long season. So rhinitis is obviously inflammation of the nasal passageways, and studies indicate that inflammation of the upper airways contributes to lower airway hyperresponsiveness and asthma symptoms. Now, it's referred to as the United Airway Disease or all one airway, and my reaction to that is, of course, duh, of course it's all one airway. We know that anything that triggers the upper airway can trigger the lower airways. There's no line of demarcation that says inflammation stops here. It can definitely trigger lower airway inflammation or asthma. So treating the upper airway respiratory tract is an integral part of asthma management. The more we can get allergies under control, the better we will be able to control asthma as well. So symptoms of allergies, nasal allergies, can be sneezing, runny, itchy nose, nasal congestion. On exam, you might see clear discharge from the nose. You can see dark circles under the eyes. We call those allergic shiners. Some children develop a permanent crease at the very tip of their nose because they're rubbing their nose so much. So they can, and actually it can lead to really much poorer quality of life because they're so miserable from these allergies. So this is looking through into the nose. You can see the swollen, the edematous nasal passages, the turbinates there. And allergic rhinitis is inflammation of the tissue lining the inside of the nose. And that's what it looks like. Sometimes I would look at a nose and it would be completely occluded. It would be so swollen. And you wonder, how are you breathing through your nose? Well, oftentimes they're not. It's provoked by allergens, can be seasonal, like tree grass weed pollen, can be year-round, because molds can be year-round. Dust mites certainly are year-round. Animal dander is year-round. Not only that, but allergens can also expose or increase sensitivity to other triggers. For example, people will say, well, my dog doesn't really bother me. But in fact, that dog can prime you to be more sensitive to other allergens, such as pollens and that sort of thing. So one can definitely increase the sensitivity of another. So treatment is avoid the offending allergens using nasal irrigation with saline, which is highly effective and not medicated, using oral antihistamines, decongestants, inhaled nasal steroids. And we'll talk about those allergy meds in just a minute. So signs and symptoms of allergic rhinitis, those itchy, watery eyes, red eyes, itchy nose, sneezing, postnasal drip, sore throat, sinus headaches, nasal obstruction, congestion, allergic shiners, and allergic crease, ocular symptoms, fatigue. It's just that people feel miserable. And if you can see here, this young man here on the upper left, those are called allergic shiners, those dark circles under their eyes. They're often very pale. They have these dark shiners under their eyes. I could spot an atopic or allergic child, a mile away. They come walking towards me. They look a little fatigued. They're very pale. They have these allergic shiners. They're very congested. That's what typically you would see. And then the allergic salute is down here on the lower right, and that's where someone is just doing that constant nose rubbing or actually rub their nose into that salute format. So there was a joint task force practice parameters in allergy, asthma, and immunology, and the recommendation there is that nasal steroids provide the most effective symptom relief of allergic rhinitis. Just as when we talk about asthma medications and inhaled corticosteroids are the most effective long-term management for asthma, well, nasal corticosteroids are the most effective symptom relief for allergic rhinitis. But it's important to use correct technique when you use a nasal spray. What you want to do is shake it well, and then nose over toes. Tilt your head slightly forward. Don't throw your head back. Direct the nozzle away from the midline, so point to the outside of the nose because you don't want to hit the septum, which is very sensitive. And then you want to spray, sniff, spray, sniff, and then alternate back to the right and left again, so you're not doing 2 sprays at one time. We recommend using saline sprays before, not after the corticosteroid spray. Use your saline spray first, rinse out the nose, get it cleared out, and then sometimes a nasal corticosteroid spray will adhere better as well. But they can be highly effective. So talking now for a minute about pharmacologic treatment of rhinitis or nasal allergies. Obviously, we would use antihistamines, which blocks the histamine receptor, intranasal steroids, which is anti-inflammatory. Then there's also cromolyn sodium, which is a mast cell stabilizer, decongestants. They cause vasoconstriction and shrink the passageways. And then there's combinations of antihistamines and decongestants. So those are the primary categories of medications we would use for allergies. So looking at antihistamines, you can see the generic names on the left, trade names on the right. I'm sure you're familiar with many of these: Allegra, Zyrtec, Xyzal, Clarinex, Claritin. So everything from Claritin on up. These are all the newer generation non-sedating antihistamines. Benadryl, chlortrimeton are older generation, highly effective but very sedating antihistamines. And then there are some antihistamine nasal sprays on the market that are also quite effective: Astelin, Astepro, and Patanase. Then inhaled nasal corticosteroids, and you'll see the trade names here. Those in red are actually also available over the counter. That used to be only by prescription, but more and more of them are becoming available over the counter. So there's Flonase, Nasonex, Rhinocort, Nasacort, Nazarel, Amneris. Newer ones, like Amneris, is aerosol-based. It's not aqueous-based, so it's not drippy, such as Q-Nasal is the same way. It actually comes in a spray that is waterless. So it's an aerosol spray, and it's not drippy, and people sometimes will like that if they don't like the dripping sensation. And then there's one more, Dymista, which is a combination of the 2 types of nasal sprays, the corticosteroid spray as well as an antihistamine nasal spray, 2 medications combined in one. And sometimes people will use those medications daily. Sometimes they use them just during the seasons. And this is obviously another low-tech way to manage nasal allergies, probably not as effective. So people say, well, I don't know what I'm allergic to. How can I find out? The best way to do this is through allergy testing. And skin prick tests are probably the most common. That's where, for children, they'll use multi-testers. So there'll typically be 8 testers on one handle, and they can put them all on at once. And it is over very quickly. It may squawk for a minute, but all the tests are on typically at once. Especially if there's 2 nurses in the room, they can put them all on, and it's over quickly. And then we watch that for 15 minutes to see what turns out to look like a mosquito bite. It might get red and itchy and a little swollen. For adults, they will often use the individual skin prick test, and there could be 70 skin pricks or more if they're going to do food testing as well. But the same thing, it's the same theory there. You watch that for 15 minutes to see what becomes red and swollen and itchy. It helps confirm the hypersensitivity to a wide variety of allergens. It can look for the environmental allergens, tree grass, weeds, cat, dog, dust mites, feather, all kinds of things, and then dozens of different kinds of foods if that's necessary. They are the most convenient and specific screening methods for detecting allergy antibodies. They are a little less sensitive but more specific than the intracutaneous test. So what that means is people will typically get the skin prick test on their back first, watch it for 15 minutes. Whatever turns up negative, they can move on to part 2 on the arm, and they'll do the intradermal test. It's just kind of under the skin. It's not a deep shot. And they can do that, and it's a little stronger concentration or dilution, and watch that for 15 minutes and then see what turns up positive there. So they're not necessarily diagnostic. You need to correlate the results with their patient's clinical history too. But they are very helpful and useful for demonstrating sensitivity not only to the patient but the patient's family, and also for improving compliance. So, we'll say sometimes, the dog's not bothering my son or my daughter, and they have this huge wheal and flare, and that was the dog skin prick test. Say, well, they really are allergic, and here's the proof. And sometimes that really makes a difference when they see with their own eyes what those specific allergies are. And if they can't do or prefer not to do the skin prick test, you can also do blood tests. So when then would you consider allergy testing, and does that help manage asthma as well? Well, if there is clear evidence of a relationship between symptoms and exposure to an allergen that a patient is sensitive to, especially if it's an unavoidable allergen like pollens, that can definitely be very helpful. If there's an allergic response all year or during a major portion of the year, if they say just during grass pollen I have trouble and I use my nasal sprays and I'm fine. But if it's more than just a small portion of the year, if they are having difficulty controlling their allergy or allergies with the current regimen that they're using, there can be significant potential benefit from immunotherapy. It's used in children 5 years and older, and young adults and adults as well, and it can be quite helpful. Again, whatever we can do to get the nasal allergies and allergic rhinitis under control can definitely impact asthma and help improve asthma control as well. And we talked last time during asthma medications about there is a new form of allergy immunotherapy that is not in the injection form, it's sublingual. So it's a tablet that's put under the tongue, and that is pollen specific. It's not as global as the immunotherapy that can include all the pollens. This is just either grass pollen or ragweed pollen right now. And they do need to start that 3 months before the season begins, and they take it daily through the season. The first dose is given in an allergy office. They're observed for 30 minutes. And then they take it at home on their own daily, and it is recommended they have an EpiPen on hand for the rare circumstance where they might have a systemic reaction. So the immunotherapy, the allergy shots themselves, can be highly effective for allergic rhinitis, allergic conjunctivitis, allergic asthma. There's also a form that they can take if they have stinging insect hypersensitivity, if they have bee or wasp allergies, and they've had life-threatening reaction to those stings. Now, most patients need a combination of therapies, so just because they start allergy shots doesn't mean they can stop taking all of their allergy meds. At some point, the goal is we hope they would need fewer medicines over time and have better control over time, but usually that's not going to happen right away because they start out building with very tiny doses and gradually build the dose over about 4.5 months. And then they're at maintenance, and then they need to stay at that maintenance dose monthly for the next 3 to 5 years. And again, the goal is we hope that will reduce their symptoms and reduce their need for medicines. The belief is that the allergy shots, that mechanism involves a deviation in the immune system from a Th2 to a Th1 response. So it's causing an immune deviation from the pro-allergic path to the non-allergic path. So it actually desensitizes them to those things that they may be allergic to. Now, weather changes are another trigger for asthma. In the fall, which is what we're in right now, there is a well-recognized spike in emergency department visits in September. One of the reasons is the weather changes. Another reason is people turn on their heat for the first time. Children are back in school, and they're exposed to the viruses that are just starting to hit the schools right now, cold viruses, flu viruses. Summer probably has the lowest number of emergency department visits because the weather is least variable, but there can still be high pollen count days, and air pollution is definitely higher in the summertime. In spring, there's going to be quite a bit of day-to-day variability, but not as extreme as in the fall. So we do see that September spike in asthma exacerbations. Also, in the winter, cold air is a well-known airway irritant, especially those with exercise-induced bronchospasm. I myself am triggered by cold air, so I'm a walker. I can walk 3-5 miles, and I have no trouble at all when my asthma is under control. But walking from the parking lot into my office on those bitter cold winter days, I sometimes come in and I can't breathe, and I'm using my inhaler because the cold air is so drying and so irritating to those sensitive airways. It doesn't matter what exertion I'm doing or how fit I am in walking, that cold air is just going to trump all else. Also hot, humid air. Some patients report shortness of breath on the really humid days, and the theory there is maybe with the high humidity comes more mold exposure. We don't really know. Windy days, sometimes people have trouble with that because wind will bring pollen and mold spores and make that airborne, and people who are susceptible are breathing that in. Air pollution is a well-known, well-recognized asthma trigger, and that happens more in the summertime during a weather inversion. So that's where the weather system will sit still and concentrates all the airborne pollutants. Now, we in Grand Rapids here, we are sort of in a valley, and we get a lot of pollution blowing over the Lake Michigan from Milwaukee across the lake, Chicago. All that air pollution blows over the lake and just settles right over Grand Rapids because we're in a valley. And in the summertime, the heat and the sunlight react with those pollutants and creates a large amount of ground level ozone. And that's a well-known asthma trigger. So it's more likely to occur in larger cities or cities that are maybe in a valley like Los Angeles, also in that valley, and you see that the airborne pollutants are concentrated over that city, and then the sunshine, which they have quite often, and the heat will interact with those pollutants and cause that ground level ozone. It is definitely a well-known asthma trigger. That's when you see those ozone alert days and the advisory days, and people who have respiratory conditions are advised to stay indoors during part of those days. Watching the weather, it's important to monitor the daily forecast, monitor the pollen count, smog index, limit exertion in cold, dry air, stay indoors with the windows closed on peak pollen days, or especially in the middle of the day when the pollen count is higher or the ozone count is higher. And keeping a symptom diary can also be helpful. We're going to finish up here with just a couple other common asthma triggers. One of the previous webinars, someone had asked about obesity, so I did add a couple slides there. The question is, does obesity link to asthma, or does asthma lead to obesity? And the answer is we really don't know. We need more studies to better characterize whether there's an obese asthma phenotype in children and whether that actually leads to the pathogenesis from childhood to adult of asthma. We know that maternal obesity in pregnancy is associated with a higher risk of asthma in children, but obesity itself is a risk factor for asthma and obesity and is also associated with increased asthma severity. So the answer is we don't know whether people who are obese are more likely to develop asthma. It looks like that's a possibility. Or does asthma itself lead to obesity, which is also a possibility if someone has asthma that's poorly controlled and they become deconditioned. And when they become deconditioned, they're more likely to become obese. So what we're finding is we know for sure that asthma is more difficult to control in obese patients. They seem to have a different type of airway inflammation, and they more often have those comorbidities like obstructive sleep apnea and GERD. And we also know that a lack of fitness and a reduction of lung volume due to abdominal fat may contribute to dyspnea. So it's important to diagnose obesity. It's important to determine a BMI for patients with asthma, confirm the diagnosis of asthma with objective measures like spirometry. It's still important to follow the asthma guidelines. Inhaled corticosteroids are still the mainstay and the most effective anti-inflammatory medication they can use, although sometimes in morbidly obese patients that response to inhaled steroids is reduced. And we also know that weight reduction improves asthma control. It improves lung function, improves health status, and reduces medication needs. So we don't have a definitive answer yet as to whether obesity leads to asthma or vice versa. I think it probably goes both ways. We're talking about now exercise-induced bronchospasm, and it is a well-recognized trigger. Most people who have asthma are also triggered by exercise. The theory there is that when you're exercising, you're breathing more rapidly, and so when you breathe more rapidly, it's caused by the loss of heat and water. You're breathing drier air and colder air because you're not allowing it to warm up as you breathe through the nose. And of course, the lungs of someone who has asthma does not like. They do not like cold, dry air, and that's what you're breathing in when you're exercising. So diagnosis can be done by an exercise challenge, and you'll see a drop in the lung function by spirometry at the end of exercise, and then it gets progressively worse for the next 20, 30 minutes. Symptoms include coughing, shortness of breath, chest tightness or pain, wheezing, or endurance problems during exercise. The way to reduce exercise-induced bronchospasm: to avoid exercise if you're having active asthma symptoms. Pre-medicating can be helpful with a bronchodilator. Warming up is helpful. Warm up for at least 10 to 15 minutes. Modify your exercise as needed. Adequate cool down, breathe through the nose, exercise regularly. The last thing you want to do is become deconditioned. And asthma shouldn't keep anybody from being active. There are Olympic athletes who are just in Rio won medals with asthma. So it shouldn't keep anyone from being as active as they want to be, but you have to know how to work around that and how to be prepared and how to manage your asthma while you're exercising. GERD, or gastroesophageal reflux disease, is another known asthma trigger, and this is when acid from the stomach contents stimulates the nerve endings in the esophagus and causes that chronic cough. The symptoms can include heartburn, sour taste. When those acidic materials enter the airways, that can also trigger an asthma reaction, and that's thought to be maybe one of the reasons for nocturnal asthma symptoms. So if we look at the possible causes of GERD, there seems to be a combination of conditions that increase the presence of acid reflux in the esophagus. There's this lower esophageal sphincter, and what happens is there's a transient relaxation of the sphincter that causes delayed gastric emptying, decreased salivation, and impaired esophageal clearance. So some of the stomach acid will come bubbling up the esophagus. And lifestyle factors can certainly play a role there too. And those include smoking, large meals, fatty foods, caffeine, pregnancy, obesity, body positioning, drugs, hormones. A lot of these things can contribute to GERD symptoms. These are risk factors for GERD. So how exactly does GERD trigger asthma? Well, the belief is that the reflux material gets past that sphincter and then can get aspirated into the larynx and the tracheobronchial tree. So the belief is that pulmonary symptoms are caused by one of two mechanisms. Either direct, you get this aspiration of acid right into the airways, and of course the airways don't like acid, it's very irritating, or indirectly, acid leaking from the lower esophagus stimulates the vagus nerve, and that just triggers bronchospasm. So it's probable that a combination of those two mechanisms are most likely. So treatment, we recommend don't smoke, don't drink alcoholic beverages. They can increase acid production and cause irritation. Avoiding caffeine and chocolate. Caffeine is a muscle relaxant, weakens the lower esophageal sphincter tone. Avoiding carbonated drinks, citrus, onions, tomatoes, spicy foods, etc. Waiting 2 to 4 hours after eating before bending over, lying down, or going to sleep. All those things can be helpful as well. Using thick feedings for infants is helpful. Elevating the head of your bed by 6 to 8 inches. Wearing loose clothing, maybe smaller, more frequent meals. Weight loss is also very helpful. There is very effective pharmacotherapy available. And then for refractory cases, there's actually a surgical option as well. Respiratory infections are another well-known trigger. Most people who have asthma will be triggered by a respiratory infection. I always say that in an individual who has asthma, there's no such thing as a common cold. Someone sitting next to me may have a cold and shake it off in a couple days. I can get that same virus, and it'll make a beeline to my chest, and I can be wheezing for weeks and end up on oral steroids. So it's important to try to avoid those as much as possible, and it can lead to that increased airway hyperresponsiveness for weeks afterwards. So proper nutrition and rest is critical to get the flu shot, not the nasal injection, the flu shot. Hand washing, avoiding those who are ill, obviously using antibiotics for bacterial infections, but just trying to stay as healthy as possible, and good hand washing are probably the two most critical. We're going to finish up here the last few minutes talking about asthma and pregnancy, and then I'll have just probably a couple minutes left. If you have any questions, you can start typing them into the chat box at the bottom. But asthma and pregnancy is something I'm often asked about, and there have been multiple studies that have examined the outcome of asthma in pregnancy. What has been found is that asthma status during pregnancy can go one of three ways. A third of the women who have asthma and get pregnant, their asthma will worsen. Asthma stays the same in a third of the women who have asthma and they get pregnant, and asthma actually improves in a third of the women who get pregnant and also have asthma. So it's a third, a third, a third, and we don't know when a woman with asthma gets pregnant which third she's going to fall in. Will her asthma get better? Will it get worse, or will it stay the same? She has probably equal odds of going any one of those three ways. Most asthma medications are as safe to use in pregnancy as in the non-pregnant state. The last thing you want to do is stop all their asthma medicines as soon as someone becomes pregnant. because we don't want them to lose asthma control. Now, budesonide, which is Pulmicort, is the preferred inhaled corticosteroid because there's more data available on its use in pregnant women. That's a category B, although those categories have since changed recently. But certainly, if someone has been on another inhaled corticosteroid, they can continue on that in patients who are well controlled on those agents prior to pregnancy. We don't want to rock the boat during pregnancy. There's been little data on leukotriene receptor antagonists during pregnancy, which would be like Singulair, but it's reassuring. There is reassuring animal data. Long-acting beta agonists or LABAs, a safety profile similar to albuterol. So again, there's not a lot of data on any of these medications during pregnancy simply because people are reluctant to do studies on pregnant women. But the belief is that these medications are as safe to use in pregnancy as they are in a non-pregnant state. It is safer for pregnant women with asthma to be treated with asthma medications than to have asthma symptoms and exacerbations. We want to avoid our asthma exacerbations because that means that can be a hospital visit, that can mean IV steroids, that can be an ICU stay. So we want to avoid that, and these medications are considered safer than that. So the goal during pregnancy is to maintain sufficient lung function and blood oxygenation to ensure an adequate oxygen supply to the fetus. So for most medications used to treat asthma and rhinitis, there are little data suggest an increased risk to the fetus. Treating asthma is paramount, but we do prefer inhaled meds to oral agents, and there certainly are some medications that we would avoid during pregnancy, and those include decongestants, some antibiotics, some live virus vaccines, brompheniramine, epinephrine. There are some things we want to avoid if we can, but for the most, in most instances, many of the medications currently used and that they're well controlled on these medications, they would be advised to stay on them. So again, just summarizing asthma medications in pregnancy, most asthma medications are as safe to use in pregnancy as in the non-pregnant state. The keys to controlling asthma during pregnancy are taking asthma medications as prescribed, avoiding asthma triggers, and following an asthma action plan. And that will actually be the next webinar. Next week we'll be talking about asthma action plans. A pregnant woman with asthma should be seen regularly by her provider more frequently if her asthma is not controlled. But finally, the known risks of uncontrolled asthma are far greater than the known risks of asthma medications for both mother and the unborn child. The key is asthma control. In summary, asthma during pregnancy can be controlled, and pregnant women with asthma can have outcomes similar to the general population. Providers can certainly try to limit medications during pregnancy, but there definitely are therapies for asthma that are considered safe to use in pregnancy. It's safer for pregnant women to be treated with medications than for them to have asthma exacerbations. I'm going to leave it there. Our time is almost up, but I'd be happy to answer any questions that you may have, and thank you again for your attention today.
This is Karen Carpenter. Just want to remind you, do you have any questions for Karen? You can type it in the public chat, or someone can just speak up and we can do it over the speaker. Any questions? It doesn't sound like there are.
Okay.
Okay. Couple housekeeping. Thank you, Karen, for this presentation. It was excellent.
Thank you.
I look forward to next week's. Next Friday, we will have the next one at noon. And just so you know, you all received your evaluations for this one, so please send them in to me electronically or fax them. Next week's is asthma action plans, healthcare literacy, and case studies. Any other questions? Okay, I guess we'll go ahead and wrap this up, Karen. I thank you again, and we'll talk to you next week. Okay?
All right. Thank you, everyone.
Thank you.
Bye. Bye.